And welcome to the annual State of the Heart and Vascular Center address. Still have the mandatory announcements that I got to go through before we actually start this. I guess it says, before introducing the speaker, that'd be me, there's some housekeeping items. So please use the microphones. Well, we're actually not going to take questions at the end of this, but we are broadcasting this live, and the recording will be available for viewing after the fact. The upcoming activities that we have are Heart of a Woman on February 7th, the Houston Heart Failure Summit on February 15th, and Robotic Surgery Summit on March the 11th. So with that, there are no conflicts other than the fact that I'm a pretty partisan guy for the Heart and Vascular Center here, so that's about as conflicted as it gets. It's not lost on me the honor of standing up here and representing you all. Thank you very much. It's also a significant responsibility, and I thank all of you for the contribution that you've made, and Emily Kao and her intern, let's see if I get it right, Amy, very good, for helping put this together. It's a massive workload, and it takes place over several months to actually get these slides. These slides will be available for anybody who wants to see them, because it's the one time of the year when we actually look horizontally across the Heart and Vascular Center. And so there's a lot of activities which you may well not be aware of. So let's start off by defining what the DeBakey Heart and Vascular Center actually is. For a long time, it was essentially a structure that existed downtown. And the initial structure of this really was a Department of Cardiology, which is headed up by Dr. Zogby, Department of CV Surgery, headed up by me, and CV Anesthesia and Critical Care. Dr. Stedman is the chair, Faisal Masood heads up the critical care part of it, and Gary Montero now heads up CV Anesthesia, that we and cover both some of the peripheral hospitals, the cath lab, and the operating room. So that is essentially the nucleus. Then we added in the Department of Cardiovascular Sciences, which is headed up by John Cook, and all of these are going to be represented, often as a collective of how we actually function on a daily basis. So the question really was, should the shingle, the DeBakey Heart and Vascular Center, be extended out across the community? And Dr. Raisner will remember this. This is not an easy decision to make, because we often competed with our peripheral hospitals, but the direction really that's been set by our CEO, Dr. Boom, is we function increasingly as a system. We certainly have ways to go in doing that, but that is essentially the way we're going to portray ourselves out into the community. And so in order to do that, we essentially created membership criteria. Those membership criteria basically have been revised many times. You don't always get it right first, but the idea is to say that we are now move the shingle out across our community hospitals, and that they basically have access to the name Methodist DeBakey Heart and Vascular Center. And there's certain rules about how that can be utilized. There's also rules in terms of how we can brand ourselves, and how our marketing department now supports us system-wide in some of the initiatives which I'll actually show you. And these basically, this is the vision and the strategies which are essentially set up to develop and maintain distinctive clinical programs, to be a leader in the CV value-based care, to strengthen and grow our physician network. We'll show you that. And we have already implemented a governance model in which there are reflections from the leaders in cardiology and CV surgery from our community hospitals. I'm sure many of those will be watching this today. So that really basically how we created this. Perhaps to our surprise, there's a lot of interest in actually becoming members of the Methodist DeBakey Heart and Vascular Center. And I'm not going to go through those numbers. You can see the majority of the participants are cardiology, CV surgery, critical care, anesthesia, and we also basically included membership for our research group. And you can see that they are scattered really across the community. And so we do have a collective group of physicians basically who started and researchers who are working together to promote the concepts of Methodist DeBakey Heart and Vascular Center. I think that's a very powerful but in evolution concept that we have here. And we'll kind of show you some of the accomplishments, what we're actually proposing for our system in the future, and you can see what the 2024 year-to-date accomplishments actually are. And I really want to congratulate Emily Kao. This would be embarrassment for saying it's herding cats. It's much more difficult than herding cats, trying to get us all basically on the same page, because she essentially has to run around, all of our different hospitals and try to keep us all in line. It's hard enough to do this in one institution, never mind basically do it in the system hospitals that we have. So this year we organised the System Transcatheter Valve Therapeutics Peer Review Programme. What does that mean? It means that we're starting to look at outcomes as a system, and we're starting to look at them internally and triage, we see the good, the bad, and the ugly in terms of outcome. They built a system cardiac rehab dashboard. We initiated, and I'll show next slide really will show you that, the CV Nursing Conference. One of the questions is, how do we build value for the people who are out in the community? Now, clearly one of the areas we can do this is how do we bring and leverage some of the educational programs that have been created here so that people in Willowbrook, in West, see and value this. I think the challenge for people like Dr. Zogby and I is, as we expand across the community, how do we continue to make people feel like they're part of this organization and not being dictated to from downtown? The Physician Network will go through this. I think the CV value-based care component, but let me explain a little bit about what that is. If we contain costs. If we can say, for example, that instead of having every coronary stent known to man, that we can boil this down to 2 or 3 stents and say 80% of the volume is going to be from those 2 products, certainly in a situation where it's not going to be absolute, there is an opportunity, if there are specific products for specific patients, we can go through that. But essentially these contracts are built around a percentage of utilization. And there is enormous savings that can come back for that. So what's the benefit to you? Well, the benefit to you is that what has been done is, and this was initially created in orthopedics, is to say, well, let's figure out how much we save. And a percentage of that then comes back to the individual institutions reflective of that percentage saving. A small percentage is taken for the Heart and Vascular Center, collectively across the system, and the rest basically goes back to the individual hospitals, whereby the CEO, along with the cardiology and CV surgery leadership, can decide, are they going to use it to support their techs traveling for education purposes? Do they want to buy a product, that was otherwise unavailable? And that's a significant amount of money. You're talking about upwards of about $1 million a year, which is coming back as a percentage of that saving for direct utilization by the people who are part of this Heart and Vascular Center. And that is an ongoing process. So one year you look at EP, another year you look at the surgical valves or TAVR valves. One of the things we're going to look at really is the sheaths that are used basically to deliver endografts, because there's a pretty big price differential in some of these. So that's the reason we would like to get you to buy into participating in this. The CV Nursing Conference, again, Emily gets the credit for helping put that thing together, but you're looking at 178 APPs, nurses from across our system. The majority of them came probably from our system hospitals. And this is something we're going to basically bring under the auspices of DeBakey Education. They'll help support this, but we clearly, the whole concept with DeBakey Education is we have an infrastructure to try and support running these meetings, but you got to have a leader who's going to put the curriculum together. And that needs to be fairly structured. It doesn't help us basically when someone comes up with a great idea and then they're invisible in terms of actually structuring it, because that's kind of where we need you to participate. So very nice. Well, I think we can grow this significantly next year. The strategic initiatives for 2025, again, I'm not going to go through all of these. Adopting a system cardiology delineation of privileges. That is no mean feat. And again, thanks to Dr. Zogby and Emily for shepherding this through. Obviously there's a different level of expertise here versus in some of the community hospitals. That actually tends to be decreasing. But trying to create delineation of privileges where we can elevate the activity, elevate the quality, I think is extremely important. We've implemented that TVT peer review program. That's what we're going to do, I should say. And for the vascular surgery group, this is going to start this year. We're going to start building system peer review. Our ability to see into the other community largely depends upon us having residents who go out into that, because then we have M&M. No residents, almost invisible basically what's going on. Well, clearly you can't function as a system and do that. And so what we're going to try and do is increasingly have system-wide review of some of the complications and the outcomes to try and improve that. And again, I'm not going to go through all of these different items that we actually have here. If you suddenly start looking at us not as individual hospitals, but as a Methodist DeBakey Heart and Vascular Center, then there is a huge volume and there's huge physical resources. Faisal here really probably does this as well as anybody, because we now starting to manage all our ICUs as a system. And so, and we'll show you some of the outcomes that have been created really as a result of that. And so if we're suddenly looking at 23 CV operating rooms, 34 cath labs, you're talking about an enormous, volume that is going through that. Fernando is basically one of the newest cardiac surgeons who joined us. Karam Nasser is here. It's all about big data. This is big data. And if we can figure out how we collect that data, I think that there's an opportunity to really differentiate what we're doing. What has been built in this organization, whether you like it up front or not, it's happening. It's data capture, okay? The virtual ICU. And one of the things, the message you said last year needs repeated this year, is that we as a group need to go from passive resistance, Big Brother is watching, to active participation in utilizing this data. This organization is very forward in terms of data capture. And there's a huge opportunity for somebody to work with these guys in building an academic career basically around this. The clinical programs are scattered really across the system. This is just kind of show you that there's a rise, for example, in the imaging activity across the system. One of the things that we've not got up here, I may have a slide on it, is we're about to have the first photon counting CT scanner in the medical center, maybe the first one in Texas, actually. Photon counting scanner is going to be over in OPC, Tammy. And essentially what it is the FDA described that as the biggest breakthrough in CT scanning since spiral CT scanning was created. And what it does is gives you better spatial resolution for less radiation, and it takes out a lot of the calcium artifact, which is ubiquitous to our patients, and it takes out stent artifacts. So it's a way of looking inside stents. It's something that is unique for a period of time to this organization. But we kind of need to take this on, evaluate it, and publish utilizing this equipment that comes in here. A word about system standardization. There is an enormous body of work that's done at each of our different hospitals, creating protocols, creating clinical pathways, creating order sets. And then it exists somewhere. Sometimes it's in a drawer, sometimes it's in the computer, but none of it is collected. And one of the things I'd really like to do over the next few years is create the playbook, or start building, we've started this actually, the playbook for Methodist DeBakey Heart and Vascular Center. So my appeal to you is that as we are doing this, please forward a copy of this to Emily. They're starting to collate these things. It's a big job. We're not going to dictate to the community, but it's the sort of thing that, for example, if it's post-op open heart weaning off a ventilator, it should be the same here as it is in our system hospitals. And again, what we want to do is take these different protocols, take them to our system CV surgery dinner, synthesize this down to one and say, this is the way that we're going to do it. It's the way that we're going to effect change and improve quality. And as we look at the different matrices for how we are judged, it's always going to be about quality. And we'll come back onto this. And so U.S. News and World Report, we've kind of bubbled along. We would really like to see us get up into the top 10 at some point in time before we exit this organization. So we've only got a few years in order to be able to do that. And that is relentless focus on the quality matrices. And this is one of the things we really need to get down to resident. We tend not to teach. It's about mortality, morbidity, length of stay, and readmissions. Those are the matrices that drive the different systems that score how we're doing this across the United States and beyond. We have consistently been ranked now as the #1 heart and vascular center in Texas. We used to be looking up at Texas Heart. We beat them a long time ago, but now we got to stay there. We ranked the top 50 in the U.S. We're nationally ranked 21 years in a row. And Methodist Hospital has consistently been the best hospital in Texas and in the top 20 hospitals, which is known as the U.S. News Honor Roll. They take the top 20 hospitals, they rank them, and they basically say you're in that. And once you get there, you really don't want to fall out of it. And so, again, this is all about these matrices that I'm talking about. U.S. News is the big glamorous thing that you see all over Houston and across the United States when it comes out. But we manage the service really using Vizient on a daily basis. And we are given targets, okay? This is a little bit like being a rep, okay? You sold $1 million worth of product this year. You got to sell $1.1 million next year. So these are stretch goals that we are given. But this is not just unique to us. This is set by our quality organization for every service in this hospital. It is deliberately designed to push us and to try basically continue to get better. So yeah, it's a little frustrating. Hey, we did great last year. Now we've got to do a little bit better this year. And that's the nature of this organization, that we continue to try to drag us up in terms of the quality. And some of the quality outcomes are really absolutely tremendous. We are rapidly growing across the system. Obviously, the big thing that's happening at the moment is the development of Houston Methodist Cypress Hospital. And for those of you basically who've driven past this is an enormous campus, tremendous opportunity to grow it. And we're going to have full cardiovascular service line that's really going to be out there. But this hospital's been designed very differently. It's been designed, as I say, there's a huge footprint, but it is designed to be able to take advantage of the technology and the future, okay? There are tracks under the floor for robots to basically move them around that hospital. They have patients are going to be able to go on and basically use voice activation in the room to order food, to be able to tell you what you want to watch on TV. And so it's a very technologically advanced program basically that is up there. We've already hired a cardiac surgeon, Dr. Malhotra. He's actually here, arrived about 2 days ago. And there's several cardiology groups who are going to be going there. Dr. Thomas Lowe is one of our vascular surgeons. He's basically moving down from the Woodlands and is going to work there. And he's going to help develop a system-wide DVT PE practice, because he's been very effective in doing that up at the Woodlands. So stay tuned basically as that develops. If you want to see one of the more impressive videos you'll ever see, is go on Amazon Warehouse Robotics. It is unbelievable. And this is kind of what Cypress is somewhat going to be like, and that these robots basically move around autonomously, pick product and deliver product. And quite honestly, you can get your product delivered, order it today, arrives tomorrow. And these robots, we, for example, as part of the Bookout Center, would like to see a fully automated operating room, that every piece of equipment in there is a robot. In the end of Dr. Atkins' case, she said, get the hell out of here. And all these little robots clear out the room. And then you say, bring in the cleaning robot. And the cleaning robot comes in and cleans it. And then I go, this next case is going to be for an aortic endograft. You have the whole thing programmed and it comes in and set it up. So these are kind of the goals for the Bookout Center. We'll talk about basically a little bit later. So let me switch now to big data and the Apella word. It's the A word. And Apella is computer vision cameras that were installed in the operating room. This is an example of get on board, because it ain't going away. What this does is essentially, if I show you a picture, is that, say that's me. I walk in that room, it draws a little box around you, and it tracks you, moving around. And the whole idea of this is that this is data. Video is data. It used to just be video, you just show it. Now it's all digitized. There's a recent paper on training surgical robots using video. That's a little scary. But this is kind of where we are going. And what this does is it automatically will notify Dr. Ramchandani the patient's in the room. Patient is draped, means you're all blue. Patient leaves the room. That's all done manually at the moment. It's all done by our nursing staff, who have to take time away from being inside of the patient to go ahead and do this stuff. And so, and we have validated, we have already presented around this at the European Vascular Society. This is highly accurate. And so at some point, and this is now being disseminated through every operating room in the system, and it's going to come to the cath labs, and very soon. And Kathy will be able to tell us when that's actually going to happen. And so, I think this is a valuable tool. It allows a management tool. If you look at from the point of view, and here's a number I've never been able to get: how much revenue of Methodist Hospital? Kathy is going to smile. Michael would be smiling if he's here. How much of Methodist revenue is generated in operating rooms and interventional suites? GI, whatever. It's probably 75 to 80%, maybe higher. I keep throwing out that number and they don't correct me, so probably low. And so it's so inefficiency in these suites is massive. And if you can shave 10 to 15 minutes off the turnaround time, the surgeons are going to be happy, the interventionalists are going to be happy, and Roberta's going to be happy. And we all love to make Roberta happy. So as we switch now and continue on this idea of data, and the virtual ICU, another pretty controversial program. Still a little controversial. But let's look below the hood, okay? We love Dr. Masood and his intensivist being by the bedside, okay? I don't think you can really replace that. But they're not capturing this data. So now we have 3 to 4 years of data that's all been collected out of our CVICU, in which you can ask, what if? Why did this patient have an MI after open heart surgery? How many have we had over the past 4 years? We had, let's say, 40. Let's go ahead and pull all the data for the 2 or 3 days prior to that event happening. And that's all going to a company called SickBay. SickBay are building the logarithms. Faisland's group already published on predicting code blues. 90% plus predictability 5 minutes before it happens. Doesn't sound like a lot. Can make a difference. It drops down as you want to go to 20 minutes beforehand. But this data is used to build these logarithms. The logarithms are used basically to drive the monitoring center to try and identify these patients before they happen. This is population health, in a massive level. And this is just some of the examples. And the DeBakey their journal publication that Faisal produced. And so I think that, again, this is just an example of where enormous amounts of data are being collected and collated and can be utilized. At the end of the day, it's all about what's the impression of us really out in the community. And one of the ways the marketing department looks at this is, who's your preferred brand? Now this is not market share, okay? This is, if you could go to any hospital in the system, where would you like to go? And we are overwhelmingly the positive group for this. Now remember, we have a much smaller footprint than does the Memorial Hermann system, or HCA. We've noticed that it's trended down a little bit and that they've started coming up a little bit, but we still basically have a very significant advantage over this. And this is kind of where it starts. Again, it doesn't mean it can't come here, but you're projecting in almost every market that we function in, Methodist is the preferred provider, and that's very important to us. And that's largely about multiple things: the outcomes, how we interact with patients. And I would be remiss if I didn't say that one of the new CMS matrices by which we're going to be judged is what the patient thinks of you. And I think this is something, a message that we need to get out to the residents, the fellows, is that this is going to be built into these scoring systems, is the patient's preferences and how the patient feels about their interactions when they're at Methodist Hospital. And where we do not do well is when the patient's asked, do you feel like there's good coordination and that the various different members of the healthcare team come and know what the other people are doing? We score very badly on that. And that's one of the things you're going to see a lot of action about over the course of the night, because we need to fix it. We know we've got a problem there. And some of this is just about communication. We tend to walk in and go, hey, you saw cardiology earlier today. What do they think? Well, the patient thinks I should know that before I step into the room. And so there are little things that we can do to try and improve this. It's very important from an APP standpoint, or residents, that they understand that you're part of this process, and that scoring is also going to reflect what your interaction is going to be like with them. So that's one of the action items really for next year, or this year, that we're going to be working on. Because we now have a system by which we can identify members of the Methodist DeBakey Heart and Vascular Center, now instead of having individual marketing in individual marketplaces, the marketing department basically creates these generic strategies that is used across the system. It will be branded locally. If a patient calls in from the Sugar Land catchment area, then they will end up basically being referred into the Sugar Land, back to Sugar Land. But this basically gives us this powerful way of reflecting Methodist DeBakey Heart and Vascular Center basically across the Houston metro area. And that's been very helpful. One of the things that happens is the whole area is divided up into regions that are associated with each individual hospital. That's kind of how this actually works and how we implement it. And so again, we don't want to feel like we're trying to drive all of these patients downtown. And very frequently now, when I see patients, hey, where do you live? I live out near West. Well, yeah, I got partners out in West. You want to come back there for follow-up? Sure. And so we then refer them on. And I think we're going to have to do that increasingly. We've changed the biannual report to a biannual report, and that's the QRS code that can take you to that. When are we going to do that? Is it this year or is it next year again? Already done. All right, so we're coming out. And so one of the things that the marketing department, up until recently, their charge was put commercially paid patients' butts in the beds. And that's what the focus was, just to drive us crazy, because you drive around, you see cancer, and we'd see orthopedics, looking for the heart and vascular center thing. Well, they've now been charged with national reputation. So that's a whole different mentality, and they've kind of stepped up to the plate. And so Yes, we still want to bring in patients, ideally commercially insured patients here. Obviously, we can't ignore the Medicare patients. We're a Medicare practice. But we actually are the Methodist Topeka Heart and Vascular Center is the best known brand in the United States for Methodist Hospital. And so this benefits us that we're now trying to look basically how we improve our national reputation. And so when you have something unique, please let Dr. Zogby or I know that that's the case. Or go directly basically to our marketing people or our PR people. I don't know if they're here or not. If they are, basically stick your over here. George, basically, and Alexis, basically the ones who really need to know that. We need to know if you're giving a big presentation at a meeting. And one of the things we came out of our education retreat is we're not really doing a good job at letting them know that Dr. Nasser is getting this award, and I think that's going to have to be figured out at Tammy level, because she's probably the only one you got to write the checks for that allows you to go travel to these things. So part of that, basically, writing the check is make sure that we actually know in advance that you're going to do this, so she can communicate out to the PR and the marketing team so that we can actually leverage that. So that's another thing we're going to work on. There's a lot of things that, but George has got to know. And I'll talk a little bit about adult congenital a little bit later, but you can see, the hospital delivers for ailing mom. This was basically a young woman from Mexico that was brought up here, and the collective team of Dr. Montero, who does the anesthesia, Dr. Duarte and Dr. Gold basically put a valve in this patient. So these are the sort of things that we can leverage. And there's Dr. Lay and all the shine and glory talking about DVT and PEs basically around Christmas time. The CV anesthesia group, I think, basically continues to grow. They interact basically with their cardiologists and surgeons across the system. I really want to thank Dr. Stedman and Dr. Montero. Dr. Gary Montero has been here for some time. Most of you know about him. He's now basically in the position of leading the CV anesthesia group. And I think really talking on my behalf as the medical director of Walter Tower OR and Rose, as the nursing director, it's been just fantastic in terms basically of getting cases done and working with us and trying to improve the flow through it. So we have numerous ACGME CV anesthesia fellows. They come from other institutions, but anesthesia has started its own residency program. I think next year they graduate the first class. So again, that's going to be important. Obviously, this is how you populate these places. Faisal's taken on, one of the nice things is when you do a really good job in the Heart and Vascular Center, you get stolen. And this is true basically of our administrators. Mark Boom came through the Heart and Vascular Center. Roberta came through the Heart and Vascular Center. Michael Garcia, and I'm going to miss out on a few other people. And then the same thing happens basically with our physicians. And so, our CV anesthesia and CV critical care group really were the best in class. And because of that, okay, you're doing a great job here. Let's see if you can handle it across the system. And really, when you look at the level of care and the outcomes that are being produced system-wide, it's really a reflection. I think it's a reflection of the CV, the cardiology and the CV ICU here, and allowing people to actually grow up and to lead these various different parts of the organization. I've talked a little bit about the cardiac arrest prediction model. That really is a function of Roberta and Faisal taking on this big data, writing these papers. I follow where the hospital is investing money. If you understand where the hospital is investing money, that's really what the administrative priorities are, and there's an opportunity for us to fold in behind that and figure out how we leverage that for the education and research mission. And this is just an example of it. And they started a critical care recovery clinic, which I'd actually never even heard of before. We always show this every year because it's really a reflection of cardiovascular health of the system. Everything else follows the imaging, and our imaging group really is best in the world, led by Dr. Zogby, Dr. Quinones, kind of put this together, and it continues really to lead this, in both from telling you what's going on. We can't operate an aneurysm without getting a CT scan, for example. Bringing in the latest and greatest technology, disseminating MRI really across the system, bringing on basic cardiac PET scanner. And many of the people who are doing this, Steve Little, for example, was head of the Echo Society. Dr. Almala, we headed up, was it the PET? Yeah, PET. So these are national appointments that recognize the quality of the leadership that is occurring down here. And really, kudos to Dr. Zogby for putting the focus on that. That's always been the shining star. There's a new shining star. So there are new programs, really, that have been developed. And for many years, we were like, We really want CV prevention and wellness here, man. There's no procedures, are they going to make any money? Are we going to lose money over this thing? Well, eventually we kind of pulled the trigger, and it makes you now wonder why we didn't do this, 10 to 15 years ago. And so and I would say the vascular surgery group here, we don't use their services enough. The peripheral vascular patient has the highest burden of atherosclerosis of any patient, who moves into the system. And we really don't do a good job in managing the risk factors. And so I would propose to you that we think this year and focus with Dr. Nasser, how do we benefit our patients in moving them and benefiting the expertise that exists in here. And so they've kind of expanded across. You can just see the volumes basically of their increased. You can see the specialty programs that have been created. I think there'll be some really interesting news about a women's heart center that they will participate on, this year, cardio-obstetrics. Anyway, I'm not going to go through all of the different activities that they've got here. But let's look at their academic productivity, because they are kind of a model that we can all follow. This is a relatively new program, and they are now knocking it out of the park in terms of research and national prominence. And I think that as you look, I had to double check the slide, to be honest with you, when I looked at it and went, that's a heck of a lot of money that these guys basically are bringing in here. And I think that Dr. Nasser is essentially set the leadership goals for this, and then you bring in, there's so many different people, don't want to mention them all, but I do want to mention Dr. Al-Kindi. I mean, he's a unique individual with a very different kind of concept of looking at risk factors, and when you look basically at the volume of trials and money that they're bringing in, truly remarkable. So congratulations, Karam, really, for helping to build this. And I think that we all can benefit from some of the unique and exciting things that are going on. So let me now bring together two different concepts. Okay, I talked about big data. The big data is being generated from our ICU. Big data is being generated from our operating rooms. Big data is being generated. Now we put bio buttons on these patients. We're going to be pulling data out of the patient when they start going home. We have brought in things like HDAI, which are risk prediction models that allow us, this is all data. And a lot of people recognize this data. And so one of the initiatives that has been created with RICE, and I'll show you another one a little bit later, and because of the kind of work that Karam has done, he's been asked really to be the Methodist representative with RICE. And you can see basically that Professor Ashutosh Sabharwal is going to head it up, from the RICE standpoint. And he's a professor of engineering. And so there are actually several things starting with RICE. Orthopedics has got a performance group, they're working with them. Gavin Britz has got basically neurorobotics, where they're trying to interface the nerves with a robotic arm, for example. This is another one, and I'll tell you a little bit about the Bookout Center, how it's going to interact with them. So this is a multi-year initiative focusing on trying to leverage the expertise from across the street. I always say that we're never going to be Harvard. We're never going to be even Baylor in terms of the basic science. So you've got to be credible. But the opportunity for us is to use this clinical machine to attract people like the groups at RICE who really want to work with us. And RICE, Texas A&M, NMed, we're pretty agnostic in terms of the people that we want to work with. And it's trying to identify what those opportunities are. So congratulations, Karam. I really look forward to seeing this kind of evolve. And, maybe worthwhile having them at Grand Rounds one day, just talking about the initiatives and where we can all tap into it. So Ferdinando, he's the guy getting involved. System cardiac rehab program basically has all been created. They have a fascinating app that's been created really to look at this, and obviously this supports everybody across the system. Again, I've deliberately downgraded the shining stars that we usually look at, imaging this year, and the valve program. They're doing phenomenally well. Again, we've been prominent in New England Journal publications. Our valve team is recognized as one of the best in the country, if not in the world. And you can see we've expanded. Kudos to them. Steve Little deserves a lot of the credit, really, for expanding this system-wide and maintaining the quality at the same time. again, I think that's the model for what we want to do with a lot of these programs. And you can see that this was reflected at TCT recently and how we were judged and ranked basically on a global and national basis, largely based upon the research. And so our structural heart team is as good as it gets, quite honestly. And thank you for looking at it from a system-wide basis. And as you can see, that's the EP program. Again, the other shining star that we've had for years that we usually talk about is, what has been created in our electrophysiology program. I'm one of the beneficiaries of that group. And so they have continued to push the frontiers, both from NIH funding and industry funding. I'm not even smart enough to even know what pulse field ablation is, but I guess we've kind of got it now. And if you look at the volume system-wide, now we have basically our own electrophysiologist system-wide. And as you can see, all these projects with R01 funding. Again, Dr. Valderabano, we've talked about how he came up with the concept when he was at UCLA, brought this concept of vena marshal infusion here, wrote a protocol to the NIH to fund a multi-center clinical trial. And that was largely run through here. That is no mean feat and an enormous responsibility for whoever actually takes that on. But that's kind of been pulled off, and now you can see he's starting to recruit other people who are coming in and getting NIH funding. We in the surgery department have lagged behind in terms of getting NIH funding. Well, we're starting, but I think you can see, what has been done basically in the various different divisions in cardiology really are tremendous examples basically of what we need to do. The adult congenital program's kind of been an evolution. Dr. Quarry basically is sitting here. Dr. Duarte, of course, heads that up amongst a group of other people. We can see that we're ACHD accredited. We're also accredited from an ECHO standpoint. And this really continues to grow. It's taken a little blip. When McGillivray, you'll see the volumes drop, but we're coming back up and almost back to McGillivray level procedures. And so they, again, more of a fledgling program than these established programs, but they're starting to leverage the resources that we've got, and that is our video production capability, these guys in the back. And so, I want to thank Dr. Quarry for taking this on in the operating room. Every operating room can record. Well, why we're not producing videos out of every operating room, looking at the PAs here, it's a question. And one of the reasons I bring this up is because everywhere Dr. Zogby and I go in the world, people say, hey, we're watching your YouTube channel. And you realize that we are actually creating content for underserved communities. Now think about that, okay? Then it changes from, hey, can I bother doing this, to being an obligation, okay? And so I think we think about this a little bit more from an obligation standpoint than it is just basically a nuisance on a daily basis. And Dr. Quarry started this pilot course internally on how to do some of these complex reconstructions. And this micro-learning series, Dr. Duarte basically has participated with Dr. Quinones really in creating this. And this also starts to help power, our YouTube channel and increasingly our journal. I do want to say something about Huey. Is Huey here? I was hoping he was going to be here. I was going to embarrass him. I think as you look at this program, I've not worked a day here where Dr. Lynn has not kind of been leading the adult congenital program. And so he's going to leave us. He's going to go to UCSF. I guess he's not transitioned in 2024. He's still here. Probably going to be 2025 by the time we let him out of here. But all these, the foundation, for everything that's been created around the adult congenital program really came from Huey. So in his absence, he can go back and look at this on YouTube and say, thank you very much for your leadership here, your partnership, and setting a vision for this program. Done a tremendous job, and UCSF will benefit from having him. Moving on to heart failure, again, huge program. Huge program. Outcomes are incredible. The production from a research and education standpoint are also credible. We talked about this heart failure program that is coming up again, Houston Heart Failure Summit on February 15th. Please sign up for that if it's something that you're interested in. There's so many components to heart failure that it's kind of hard to keep track of. But they've done it, basically, and I think that the group basically is very cohesive. It covers everything from, early on heart failure all the way through to heart transplants, VADs, and you'll see basically Dr. Martin basically heads up that group, but you can see the size of the group of people, corporate surgeons, anesthesiologists, always who are involved in trying to grow this. And it's something that we really need to focus on and to grow in the future. The outcomes, we get audited in this fairly regular, are really excellent. And I think you can look at the volumes. We did about 100 heart and VADs this year. We'd like to see that grow. And that's one of the things we want to focus on, is to try and see that basically pick up again in the next few years. You can see that the lung transplant volume, again, Eddie gets a lot of credit for this. He's picked up in our multi-organ transplant space here, important. Dr. Guha here basically has got a patent for a molecule, which I don't even understand how it works, but increasingly these are the kind of things that we want to actually see in the future. So congratulations. Again, this is one of the reasons for putting these things together. I had no idea. Did you know they had a patent? Well, that's good. So we got a patent, so that's pretty nice. And we look forward to a huge amount of revenue from that coming back into cardiology or the heart and vascular. There's a little nuance there. We'll have to figure out how those patents basically are allocated. But congratulations, that's really kind of cool. And you can see a large number of clinical trials with a number of different people. You can see there's like 5 different PIs basically here doing this, and gene therapy trials which are going to be beginning. So thank you again for giving us all of this. On the vascular side, I said we lagged in NIH, but we're getting there. So where's Tricia? Tricia can put her hand up. She's still here. So Tricia Roy spends 50% of her time doing research. She's focused on using imaging, a lot of the imaging technology that was brought here because of our group, to look at peripheral arterial disease, set up an incredible model that now basically industry, I think all industry is going to have to bring devices in here to be tested before they set out in clinical trials. And then, so Tricia, phenomenal. That lab is rocking. And then the other thing that's new this year really is when Charo has built our vascular robotic. We are easily the lead center in the United States for doing vascular robotic. Everybody thought it was too hard. Well, it's not too hard for Charo. He's done it. Oops, we go back to Charo. And so there are a number of different procedures that we've taken on. I'm the president of Southern Vascular in 2 weeks, and I'm going to talk about digital surgery and robotics, and a lot of it basically is that work. And again, the ability to have a place like Mighty, which has got a dedicated robot where you can practice, move this into the clinical arena, and we're going to be the main training center for people from around the country. That's how you improve your reputational score, by doing things like that. As I mentioned, there's really 3 big different departments, that focus or encompass it, make up the Heart and Vascular Center. And John Koch really heads up the Department of Cardiovascular Sciences. John came here from Stanford. I will say be careful when you invite somebody as a visiting professor. I went there as a visiting professor. They said, "We'll have you meet a few people." And one of the people I met was John Koch. And I went, we have an opportunity for you. And that was probably 15 years ago, and he's been down here since then and has built multiple different centers. He brought in, don't blame me, the RAG concept. And the RAG concept basically is how we manage the research across the Heart and Vascular Center. So, for example, RAG means Research Affinity Group. It doesn't matter if you're a cardiologist or surgeon. If you're doing structural heart research, you're in the Structural Heart Research Affinity Group. If it's imaging, they're an imaging group. Each of those different groups has its own P&L, and the RAG leaders manage that P&L. And at the end of the day, the deal that we struck with the Heart and Vascular Center is that all rolls up into one Heart and Vascular Center P&L, and that rolls up into the academic institute. And so we have to make that budget work. And where's Casey? Casey, another guy we stole from Texas Heart, leads the entire operation, and we've never been in deficit. We've always kind of made money, and then what we kind of do is go back and say, okay, which RAG produced the majority of the money, or is there something we can use this money for, that benefits the entire collective here? But John essentially was the one who brought that concept from Stanford. Yeah, nobody said it's perfect, but it works pretty good. There's a few things we need to change. And if you look basically at what has been done, he divides us up into the regeneration labs. That's clearly what he started. And you can see these various different labs and what they're working with. We really need to figure out a mechanism by which we engage in them with them a little bit better. Because each of these labs is highly functional. Most of them basically have NIH funding, and they're really looking for collaboration. And so figuring out a way in which we interface with them a little bit better. The RNA therapeutics lab is just boomed. In fact, now there's an RNA manufacturing facility here. There is a commercial relationship with an RNA company that uses our facility and are using some of the technology that was developed largely under John's auspices to commercially create RNA. Some of the vaccines, like COVID, was an RNA vaccine. So again, it is an area that has really kind of taken off. If you look in composite, because this is kind of how we report it at the end of the year, is what is all going on. You are the biggest research operation in Houston Methodist Hospital. And so, you know, we compete based upon our ability to differentiate what we're doing. We're not the easiest place to bring in new products. Sometimes that's a good thing. But we do if you have a new product that is highly differentiating for us, that will drive the marketing, drive the national reputation, that's when we need to get involved in it and talk about it. I often use TAVR as an example. The first TAVR cost $35,000. That wipes out the contribution margin. We didn't get in that trial, okay, but we subsequently got in the next trial, and that's when Messrs. Kleiman, Reardon, and Little kind of went to work and had the biggest recruitment in the country. That led to several of them being the national PIs on the next few trials that come up. That's the goal. That's national reputation. That leads them to report that data, usually at ACC or TCT. That's national reputation. And then what happens after that is, once it gets FDA approved, well, you got to train the entire workforce of the United States. Well, where are you going to do that? We're going to do that in the best training center that exists, and that's Mighty. And so one of our challenges is that I will say we're a budget-driven organization. That's good. Well, really not. We're a budgets-driven organization. And one of the challenges we've got is understanding the composite of the benefit of something like that. But nevertheless, I think we certainly have a sympathetic ear from the administration. Whenever we get something that's highly differentiating, let us know and look to see how we actually bring that in. One of the things we're really proud of is the postdocs. And the postdocs, we have a huge number of postdocs. We had a few problems basically along the way in terms of supervision and exactly what's going on. But if you look, this postdocs are what drive our research. And it's one of the things that Dr. Zugby and I are very protective of. These are people who come here, they spend time with us, they present, and they go home. You may think you're kind of doing this under the radar screen, but not anymore. You've got the Queen Bee basically is going to take care of you. And so we know exactly what you're doing. And we will create the scorecard at the end of the year to see what is the value of this postdoc program to the Methodist DeBakey Heart and Vascular Center. And you can see it's pretty darn significant. And a lot of them have come out of there. And it's one of the things I'm very sensitive to. We bring somebody in here, and the goal is to, in a residency program, that we are allowing you to create the things that will make your CV better, and that we help get you in front of people in order to get you into residency or a fellowship program. And so huge number of clinical trials, a lot of them PI initiated, which tend to be the exciting things that we're involved in. The main message from this slide is, you used to be down here, not anymore, okay? Now the RI has built a research support group who can travel really system-wide to our other hospitals. And so whereas down here there may be one or two nurses who support or coordinators who support a particular trial, there's not that volume out in the community, so they may support multiple trials. But if you look, for example, we've actually kind of been very successful with the vascular surgery. We now have 9 different trials which are cutting across the system. That allows us to enroll faster. It allows remember back to how do we make people feel like they're part basically of this organization. And one of them is to kind of push out these new technologies so they get excited about it and they want to feel involved in it. Obviously, there's some challenge in the monitoring, but I think the AI, basically, the Academic Institute has done a great job in helping to do this. And this is one of the things I'd like to see this next year become an even higher number, because if we leverage the power of the system, we can take this organization basically to another level. So, CV education certainly undergone some gyrations over the past few years, but I think we finally got it back together again. Chris, put your hand up. Basically, Chris is the leader of this. He's a Mexican physician, doesn't practice here, but he's got a clinical background, can help you. He's the point person to help with the other folks basically who are part of DeBakey CV education. And we're continuing to expand that structure. This will have double this number of people when I give this presentation next year. And DeBakey CV education, again, you can see we have a course catalog. You can see on the right side the number of different programs that we're running. Once again, we are running the biggest number of these training programs of any center of excellence here in the United States. Not in the United States, and Methodist. Probably is the United States, actually. And you can see all of these different programs. Once again, you talk about national reputation. The concept here is that one of the challenges we've got is we've not got 20 years worth of producing residents who on US News and World Report, all of this ranking is done through Doximity. Through Doximity, if you're not on Doximity, you can't vote. If you're on Doximity, you get things which say, hey, where would you send a patient to for, PCI, for example? And so there's 5 slots on that, and you vote. Well, typically, first one goes to where you did a residency, second one goes to where you did a fellowship, so the rest of the people in the country are fighting for those 3 slots. We don't have, 500 residents out there who we've trained, so we're a little bit behind the 8 ball. So part of this concept is, let's bring people down here, okay? Trying to explain Methodist Hospital, Methodist DeBakey Heart and Vascular Center. I will say to people, I'm surprised I got any hair left, because I've given so many presentations, and then they'll say, any questions? How long have you been at Texas Heart Institute, Dr. Lumsden? There goes some more hair. And so it's just the problem is that we exist in Texas Medical Center, and one of the most complex environments to try and explain. But once they've been here, once they've been in Mighty, once they got the picture taken with Dr. DeBakey out there, once they've seen the cath lab, they get it. So part of the national reputation strategy is, say this tentatively, I'm going to hear from the marketing department, but this needs to be part of it. You bring people down here. Somebody else is paying for them to come down here. We walk them through this organization. Once they've met you, once they've seen the organization, they know exactly what Methodist says at that particular point in time. So, education, national reputation, this is like a complex Venn diagram that all kind of overlap with one another. But this also, as I say, helps that enormously. Not only is it used for education, increasingly, and you can see the 3 people who are actively using Mighty and the imaging resources up there for doing research. The YouTube channel, I've kind of alluded to, that you can't keep up with this because now it's over 120,000 subscribers. Less than 1% of YouTube channels have 100,000 subscribers, okay? And so if you take purely medical, there's some pretty nasty looking YouTube channels up there that probably got millions on there. We are in rarefied air, okay? This is the front face of our Heart and Vascular Center to many people around the United States. There is not a single cardiac, vascular, cardiology applicant who comes here that's not aware of this. And so once again, I go, and that's just the US. Beyond that, you are providing high-level education to anybody who's got internet access around the world. And that's why I say is that it is free, good price, free, and it allows people to see what we're doing. And so, once again, I think it's something we need to double down on. Really like to kind of see this get up to 200,000. It's kind of plateaued a little bit. We've got a lot of the people who are the easy pickings. Now we've got to figure out how we go beyond that. The journal is another very important part, basically, of people seeing who we are. And Levon and Dr. Q have converted this over to the electronic format. If you've not seen this, then please look at DeBakey Cardiovascular Journal and look at the electronic format. And I noticed that some of the webcast discussions about the journal are now cited in PubMed. So we're starting to look at how these videos potentially get cited with a little bit extra work, and that would basically be enormous. The other initiative I was going to talk about, is the Bookout Center. The Bookout Center is, Mr. Bookout, everybody knows here. The Bookout Center really is a concept, started off around robotics. Mighty has kind of rolled into this, so there's really 2 parts to the Bookout Center. One is the robotics and imaging part of this. I'm interested in robotics, but we're all interested in imaging. The robots will be driven by the imaging. The patient-specific imaging will be used to control those robots. Some of them are catheter robots, some of them are surgical robots. This is not just a Heart and Vascular Center, but just like what Dr. Nasser has done, you got Heart and Vascular people running this. We want a piece of the pie out of the resources that are coming in, and the Bookout Center is the same. This is a Houston Methodist-based idea, but we really want to extend. We want to have the Heart and Vascular Center actively involved in it. Stuart Core has hired this innovation engineering core, and these are the folks who are involved in it. I don't know if they're all in here. They can stick their hands up so we can find them if need be. But these are remarkable people. Austin, is working in virtual reality. We're on the point of recruiting an expert in virtual reality as a joint appointment with Rice. Kelvin is a biomedical engineer. I would say Billy Cohen, who developed the artificial heart and several other things, said he's the best biomedical engineer he's ever worked with. Congratulations that we got him in here. Carlos, basically, is on robotics and computer vision. And Anna Moisey belongs to Dr. Moisey, sitting in the back of the room. She's a data scientist, and she's going to help work basically with Fernando and Karam Nasser. And just to give you an example of what can be done, let's see if this actually works, is again, recording. This is my operating room, and this is going to be built in virtual reality, okay? So, and what they're doing now is I want to be able to train our trainees in VR and how to use these C-arms. I will say, next to me, what's the important piece of equipment in this room? It's that C-arm. And so can we do this in a VR? And this is just an example of what can be done. I think in the future, as we get this recruit on board with Rice, I think all training is going to be done in VR. And we have a capability of leading the cardiovascular world in terms of our ability to actually do that. Pumps and pipes, we had recently, biggest attendance we've had over in TMC3 Helix Park. TMC3, for those of you who have not been there, is remarkable. It's all about innovation. Methodist now has, like 100,000 square feet of research space over there. A little more remote, obviously, than the RI, but the RI basically is already full, and we need to move it forward from that. A lot of these fancy things can't be done without the foundation that Dr. Zogby and I work with very closely. Remember, there was no fundraising or foundation at Methodist. It used to be Baylor. So this has all been built from scratch. And if you look at the number of endowed positions that we have now in the Heart and Vascular Center, so what does that mean? It means if you sit here with the $2 million endowment, it probably generates $100,000 a year. You can't spend the $2 million. That's going to be there in perpetuity. So these are never going to go down. We just kind of add to that. But if you have a chair, then you have $100,000 a year, for example, perhaps more, that you can actually use for research, for education, and things that you want. And so this is a hugely important part, basically, of what we do in raising this money to support these chairs, to kind of let you do the fancy things like PI-initiated clinical trials, for example. So I think at the end of the day, let me just go and say, I want to stop there and just say one other thing before I finish. And that is to thank Dirk Sossman. It's sad in that people that you've worked with for close on 20 years. Dr. Dirk Sossman is the head of the Academic Institute. He was brought down here initially from when the Baylor Methodist split occurred. We had nothing. We had no academic infrastructure. We had a relationship with Cornell, and Tony Gatto basically said, Dirk, I don't know whether he volunteered or was told, but you're going down to this place called Houston and you're going to help rebuild the entire academic structure here. And so he came down, he's had many roles, chief medical officer, head of the PO, now head of the Academic Institute. On all honesty, he's probably done more to shape this organization than almost anybody else has, particularly involving the PO and the Academic Institute. And so he's in the process of retiring. I think that we should all give him a round of applause and say thank you for what you've contributed. So with that, I am right on time, which is unusual. And I'm going to close it up and say thank you all for all you do for the Heart and Vascular Center. Thank you. We are adjourned. Thanks.